All right. So tell me, Dr. Rubin, how did you get started in female sexual medicine?
So, like a little girl, I always knew this is what I wanted to do. No, this is definitely not what I always thought I was gonna be doing. In med school, I found surgery fascinating. I really liked kidneys as part of the pathophysiology, and I shadowed a urologist who I just thought the surgeries were so interesting, the problems were so interesting, and then I worked really hard. I found my way into a urology spot, and it was at a urology meeting that I saw my mentor, Dr. Erwin Goldstein, speak at a course. And I literally dropped everything. I called my boyfriend at the time, who's now my husband, and I said, oh my God, there are people who do exactly what I want to do. This is absolutely amazing. And he said, oh my gosh, I've never heard you talk like this before. And I walked up to Goldstein and I said, I'm Rachel Rubin and I'm going to be your fellow in 5 years. And that was it. And now I help teach the course with him every year at the AUA, which is pretty incredible. I realized that sex was something that's hard to talk about. It was hard for my attendings to talk about. It's hard for people to talk about. And I didn't suck at it. I wasn't afraid to ask the questions. And it turns out if you ask people questions, they'll give you answers. And if you make them feel comfortable and confident, they will tell you anything. A man, a woman, if my door is shut and they're with me, I can get anything out of them, really. And I found that male sexual function, female sexual function fascinated me. It's about a couple. And so that was sort of I knew I needed to get trained, and I did it in the only fellowship in the entire country that even acknowledges women's sexual health was with Dr. Goldstein out in San Diego. So I'm a special breed of graduates.
That's amazing. That's amazing. So you went and spent a year in San Diego, and then you moved back to the East Coast, and right now you're in DC, correct?
Mm-hmm.
Awesome. Full-time sex med.
Yep, I do full-time sex med. I'm 4 days a week in private practice where I do basically a boutique sexual medicine practice where you come in, I take over an hour with patients the first time they come to see me. I talk with you on the phone before you even come to see me to make sure it's the right fit. I work really hard to build multidisciplinary teams. So if you come to see me from Colorado, I'm going to make sure I find the best physical therapists and sex therapists in Colorado who I can collaborate with, because you have to build a team around you of appropriate, team members. So I really work hard, and you can't do that if you see 50 patients a day. You can't be the quarterback when that happens. And I work really hard to be the quarterback for patients' quality of life.
Awesome. Tell me the biggest misperception that people have about your job.
Everyone thinks I'm a sex therapist. Everyone assumes I'm a sex therapist. They say, oh, well, and it's because I talk to people. It's because I spend an hour talking to people in that first visit and half-hour follow-ups. I am definitely not a sex therapist, although it turns out if you talk about sex and ask people questions about sex, you, in their minds, are just a therapist, which is very funny.
That's awesome. What do you think urologists add to the sexual health part? Because I think in urology, erectile dysfunction has been around for years, but as far as looking at the whole couple and women, how does a urologist add their own unique spin on things?
So I actually think urologists are inherently comfortable asking patients questions about libido, about erections, about orgasm. We know all about retrograde ejaculation and what medications we have sexual side effects. This is bread and butter to a urologist. We're also genital doctors, right? I'm a penis doctor. You can't take yourself too seriously when you're a penis doctor. And so you have a sense of humor. You enjoy talking about fun things, and people feel comfortable with you. And so I think this idea, as a urologist, I am trained, just like every urologist is trained, to take care of men and women. When you are boarded in urology, you have the ability to care for the urologic problems of men and women. So if we're taking care of genitals, if we're taking care of orgasm, libido, genitals, why is it only for men? And so adding on that female component, I think, is so easy for a urologist to do. You just have to be interested. Gynecologists should not be responsible for every aspect of women's health. It's not fair, and it's certainly not doable.
Yep, that is so awesome. Tell me about the transition. Let's talk about the transition between a woman who has good amount of estrogen and then the perimenopause years and then the menopause years, as far as sexual health and kind of what are common scenarios that you see with hormone transitions.
So menopause is, I think, has the worst PR campaign in the history of the universe. Everyone assumes that menopause is hot flashes and night sweats. When they go away, you are done with menopause, which is absolutely ridiculous. Menopause is the gift that keeps on giving. It never stops. It keeps going, and every part of the body requires hormones. Your brain, your bones, your skin, your hair, your vagina, your bladder, um, everything, your libido, your interest, your mood, your sleep. And this idea that once you stop any hormones in your body, that you're just going to function normally, that you were used to when you had hormones, it doesn't happen. And so, unfortunately, doctors don't get good training in menopause, and they don't think globally about a whole person, right? If you come to me for hot flashes, okay, let's treat the hot flashes. If you come to me for pain with sex, okay, let's focus on those issues. But what I really try to do is talk to women and say, let's take care of all of you. Let's think of what's going on in your whole body right now. And so this idea of you are fertile and then you go through perimenopause, which is arguably worse than menopause because your highs are highs and your lows are low and you feel awful. You get hot flashes. You're not sleeping well. You get brain zaps, which are like, oh, geez, what is this called again? I can't remember. Tip of my, oh, it's a pen. You become more irritable. You become more anxious. And so what do? We put you on antidepressants. We put you on sleeping pills. We tell you to take calcium supplements instead of saying, there's something missing here. And so, as we've spoken about before, treating menopausal women is one of the most rewarding things that I do as a urologist, which is funny because I'm a urologist. It wasn't something I was trained in residency, but I did get a lot of training in fellowship because I really help the whole patient. I had a great patient who came in and she said, Dr. Rubin, I came to you for pain with sex. Yeah, it's not painful anymore. It's fine. But I didn't think I would like it again. I didn't think I would enjoy it and think about it again. I didn't ask you for that. And it was just such a perfect example of if I had just treated her locally, would I have helped her as much as I could have? And the answer is no.
Awesome. Where do you see, in America, kind of coming out of this women's health initiative study to the point of saying hormones are safe in the appropriate person? Where do you see that in 10 years?
God willing, in 10 years, hormones will be, menopause management will be something that everyone is trained to do in their respective training programs. It will not be thought of as a dirty word, just like testosterone and prostate cancer in the urology community used to be a dirty word. There will not be as much snake oil out there and compounders and thinking that everything has to be done by a naturopath, and instead more evidence-based hormone therapy, just like evidence-based hormone therapy for men and evidence-based hormone therapy for women. That WHI study did a whole lot to really hurt women because of the press that it got and the way people read the studies and the way that it was initially brought out. And I think over the years, hopefully we will work hard to undo some of that damage.
Awesome. I think a big misperception that women have is that their body holds any testosterone in it. Can you talk about the role of testosterone in women and then specifically with sexual health?
Absolutely. So hormones is something that everyone sort of puts at a basic level. Hormones, good, bad. Hormones, women estrogen, men testosterone. And it's so silly, right? Everything is so much more nuanced and gray than that. So if you actually look at it, women have a lot more testosterone and androgens in their body than they have estrogen. It's just that compared to men, women have about a tenth of what a man has in his body. So if a man has a testosterone of 500, maybe a woman should have a testosterone of 50. Now, that's not medical advice. It's a lot more complicated than that. But women need testosterone. So it's very similar to how I treat my male patients. If you have low libido, if you have low energy, if you have any problems with your pelvic floor, we know testosterone is important for muscle health. And so systemic testosterone can be very helpful for those things. We know that the vulva is very androgen dependent. So when I see women who have painful intercourse, often a localized testosterone approach can be extremely helpful to my patients. And so testosterone is also a very political issue. In order to get it approved for women by the FDA, it takes $1 billion in a 10-year study, as opposed to if I want to get another kind of testosterone approved for men, it's 6 months of data and like $10 million. So drug companies are not going to put the money into approving something for women that may just help their libidos.
Yeah, I agree. I think the barrier to entry for treating women, you can't have any risks or any harm. But if you look at male studies, they're held to a very different standard. There certainly isn't equality there.
Yeah, look at the birth control for men that they tried to put out. Men are getting, a tummy ache and a headache, and we can't possibly have fatigue be a side effect. It just, the benchmarks change. They're so different with men and women. If you looked at a medication like flibanserin for low libido, this idea that a woman could take something that could potentially make her dizzy because it helped her libido. Oh my gosh, stop the presses. We can't possibly approve this medication.
Right. What would you say to a woman who saw an ad for the new FDA-approved meds for hypoactive sexual desire? So she sees these ads and she goes in and asks for the medications. What would you say to her as far as finding the magic bullet?
So, like with all patients, it all is in the history, right? I don't just call up, there's like these telemedicine things. Well, if I go on to, a website and type in my name and age and ask for Viagra, they then mail it to me. I don't believe in that type of medicine. I want to get to know patients. I want to understand where they come from, where they want to go. Their goals are going to be totally different than the patient after them. And their couple, their relationship, or their wanting of a relationship is going to be different than the person after them. And so it is not a one size fits all approach. It can't be a one size fits all approach. The meds are a tool in my toolbox that I can then help get a patient to the right answer. And that answer may be sex therapy. It may be sex therapy and medications. It may be fixing the pain. It may be working on the relationship and communication. The idea that medications are going to fix every problem, we know that's not going to happen. But do women deserve the option to try a medication to see if it can boost dopamine in their brain? Absolutely. It's an excellent tool. And we now have 2 FDA approved options to improve libido in women. And like most drugs that work on your brain, it works about 60% of the time in people who take them. And when it works very well.
I think, some of the pushback I've seen from the sex therapist community is the medicalization of sex and sexual dysfunction. And to me, it can be a boon as well, because it's starting conversations that wouldn't otherwise be started, because you're saying, hey, this might be a medical condition that could be improved by a medication, instead of saying, hey, this is absolutely not anything that a medication can fix. So I think it really just opens up the conversation, but it still has to be individualized.
So I'm on team Dr. Casperson there, because I fully believe in medicalizing some sexual dysfunction, a lot of sexual dysfunction, because the last time I checked, your brain was a part of your body. And so if your brain is not helping you to be more aroused, more relaxed, then sex therapy is a medical therapy that we can work on to better communication and sexual function. This idea that something is in your head versus something is physiology doesn't make sense to me. So what are the tools? Just like antidepressants, we know antidepressants work better when you're in therapy. I think the medications for sexual function are going to be exactly the same. We know erectile dysfunction medications work better when you're in sex therapy, because what is sex? Fundamentally, sex is about pleasure, intimacy, and communication. Who can't get better at those things? Everyone can get better, right? I always say, nobody is so good at sex, they can't get better. And so how do you get better at sex? You try new things and you communicate differently with your partner.
What would you say to somebody who's never had a conversation with their partner, in giving them some tips or tricks to start that kind of intimidating, scary conversation?
So again, I would say go see your local sex therapist, because everyone benefits from sex therapy. And remember, I'm not a sex therapist, but I ask them probing questions in terms of, you find out what people do for work, and you say, okay, you're a consultant, right? For whatever industry. When you plan for a big meeting, you talk about it, you have an agenda, you set it up, and you have a plan. Then you have the event, the meeting, whatever it is that you work really hard to do in your job that you're paid to do. And then guess what? Afterwards, you have an after action. What went well? What didn't go well? What do we do to make it better next time? Nobody does that about sex. Never. Nobody talks about it. There is never a debrief. There's never a pre-brief. And those conversations need to happen not while it's happening. It happens over the walking the dog, the breakfast table, the date night, having hard conversations shouldn't be done when you're vulnerable, when you have no clothes on, when you don't know how your partner is going to respond. And often the best way to have them happen is through a third party where you hire your own consultant to say, okay, how do we do this? How do we do this going forward? And so by me medicalizing it, I actually give patients permission to go to sex therapy because they realize that sex therapy works when your relationship is good, right? When things are good, you already communicate well about the kids. You already communicate well about the house stuff. You're not fighting. You're not on the brink of divorce. How do we make the next 40 years of our marriage even more spicy and fun? And that's where they say, oh, well, that makes sense. Sex therapy now sounds like a fun consulting thing, not I'm, deficient and I need, help in some way.
I really like how you kind of use analogies outside of sex to normalize the conversation and to say, hey, this is just like this scenario that people can relate to. And then it's not this big elephant in the room that they've possibly never talked about in their life.
The other thing I really like to do, and that's why I take so much time with patients, is I educate. I show them slides. I show them pictures. I show them PowerPoints. And I really encourage them to bring their partner, their person, to the meetings. Some are comfortable the first time, some really want to bring them the second time, because it gives them permission to talk about their own problems in a medical way, right? Well, the reason sex hurts so much, look, Dr. Rubin explained to me that it's happening in my vestibule, which is at this part of my body, and this is what it looks like, and this is how it affects my pelvic floor. So when, this is why, and they can use real medical words instead of just saying, it hurts down there, Dr. Rubin, right? And you give them power. When you empower someone with knowledge of how their body works, and this is for my male patients and my female patients, if my male patients know how Viagra works, they're going to use it and they're going to be excited to use it instead of just using it, oh, geez, I have to take my man pill, and they feel terrible about themselves. When you give them the confidence of they're taking it because they have high blood pressure and diabetes and they need more smooth muscle relaxation, then their partner gets to chase them around the house and say, honey, go take your muscle relaxer, right? Not, oh, do you take Viagra because I'm not pretty enough anymore? You empower them to understand this through the medical lens, which really helps couples grow together.
Awesome. Super powerful. Can you talk about birth control and what it does to sex?
Sure, happy to. So I will put a big disclaimer. I am not a gynecologist. I do not prescribe birth control. I have never prescribed birth control. I look at birth control through a very specific lens, which is not a very popular opinion. But I see a lot of problems, medical problems that can happen with birth control. Now, we've all heard women on birth control can have mood issues, weight issues, certainly libido issues are something that's talked about. Data shows women on birth control pills have a higher need for anti-anxiety and antidepressants. So we know when, and I say this all the time, when you play with hormones, there are consequences, right? Period. Some are good. Some are bad. So I love the idea that birth control allows you to make choices for your own body of when is a good time to get pregnant. I love that idea. But when you add a hormonal component to a birth control pill, you alter the hormones in your body, which can have negative consequences. For some people, positive consequences like acne, can be improved very much on birth control. The reason acne gets better is because it decreases testosterone in your body. Wait a minute, I thought women only had estrogen and didn't have testosterone. So it's, again, that testosterone thing that we don't talk about. That's why the acne gets better. But that's also why your libido gets worse for some women. And remember, I said the vulva has a lot of androgen or testosterone receptors in it. So when you take birth control pills, it can really mess up the testosterone locally in the vulva and cause searing, raw, hot, burning pain. And so women who put tampons in, women who try penetrative sex. And I shouldn't say just women, anyone with a vagina or a vulva certainly can have these types of searing, hot, raw, burning symptoms. Just to give you an example of anyone with a vulva and or vagina, I have a transgender male patients who had their ovaries removed. Okay, so 30 years old, ovaries removed. That now puts you in menopause, so you don't have estrogen or you have a lot of testosterone because they're on exogenous testosterone, but you can create a hormone imbalance locally in the vulva and the vagina. And so anytime you're playing with hormones, it may cause consequences to the tissue. And so birth control, when I see a young woman who has pain with sex and I see birth control on her med list, I know before she walks in my door what my initial plans are going to be. And that's usually stop their birth control pills. I often will add a local estrogen testosterone concoction, or I've had a lot of luck with Intrarosa, which is vaginal DHEA. I had a patient who I just spoke to very recently who had never been able to put a tampon in before, has been using Intrarosa for 6 weeks only. And she got on the phone with me and said, well, I don't know if it's working, but I put tampons in for the first time in my whole life. And I'm like, what? Of course it's working. It's only been 6 weeks. This is so exciting. So really important to understand the hormonal concept of birth control.
Can you talk a little bit more about Intrarosa, the DHEA, and who you think of that for versus estrogen? And second question on that, post-cancer patients with both DHEA and estrogen.
Well, so that's a loaded question. We could certainly, I'll try to simplify. So Intrarosa is vaginal DHEA, which DHEA is the precursor. So if you look at your own hormone pathway, it starts with cholesterol and it becomes different hormones. It becomes progesterone and estrogen and testosterone and even cortisol, aldosterone for blood pressure. So that's kind of the steroid pathway we all learned in medical school. DHEA lives somewhere before estrogen and testosterone. And so it's a precursor hormone, if you will. You can buy it at GNC. It's a supplement. But there is an FDA-approved version that contains just DHEA and palm oil. And it's very, you put it in the vagina every night at bedtime. And the way that they feel it works is your body's enzymes then converts it into estrogen and androgens locally. It does not increase estrogen in the whole body. It does not increase testosterone in the whole body. There are reasons why I wish it did and why I like doing those things. But especially if you're someone who's had breast cancer, a hormone-positive breast cancer, you may be told by your oncologist or maybe more fearful that hormones are very dangerous in that setting. And so this is a local therapy that you can use to help the tissue locally. There are, the reason I like Intrarosa is it adds theoretically that androgen component as opposed to the local vaginal estrogens, which just add the estrogen component. So all of them sort of are used to treat genitourinary syndrome of menopause, or GSM, and they're all great. It's just a matter of which one can you get your patient to actually use, and getting them to stay on it is those are the challenging ways to do it. So there are no studies on DHEA or Intrarosa in breast cancer patients. I'm hopeful when pandemics are over that these studies can start. I knew they had planned to do a study, but with politics and drug companies, there is that medication is actually in flux a little bit because women's health products don't sell the way that they should. There is no formal study on breast cancer and vaginal DHEA, although I am hopeful that it really, because it doesn't increase the blood values of estrogen and androgen. So how is it going to worsen a breast cancer? How is it going to cause a blood clot? How is it going to cause a stroke if it doesn't even get into your bloodstream? But many of the studies on vaginal estrogen or local vaginal estrogen show no increased incidence of breast cancer progression, of incidence of breast cancer, worsening breast cancer, and even the Cancer Societies, come out and say for severe symptoms, yeah, we think it's okay. Obviously, anytime you add a hormone and you've had a history of breast cancer, as your quarterback, I'm going to work with your oncologist to make sure you're on something that everybody agrees on and that we can all feel comfortable with. I just had a patient reach out to me who moved away, and she was this horrible story, just diagnosed with a breast cancer, hormone positive. And she said, I am so excited I'm terrified of going into menopause, but I'm so excited to know that you're in my court because I know you're going to help prevent bad things from happening and that we can all work together to preserve my vagina, to preserve my libido, and to still live and have a good life, living as a breast cancer survivor. Because what is the point of keeping people alive from cancer if we don't keep them living?
I love it. What's the role of the supplemental DHEA that you can get on Amazon or in health food stores as far as kind of your average person who's interested in preserving their sexual health and vitality? Are the societies promoting kind of that supplement, or where do we fit that in?
From what I understand, if you take it orally, it is like a small drop in a bucket, like it's not enough. And so from what I understand, and I'm not as up to date on the literature, but from what I understand, the supplement orally doesn't necessarily make a huge difference in the literature. So I would have to say we should do a literature review, and I'm not sure, but I don't see it widely promoted by the societies as making that much of a difference. Does it harm you? We always struggle with supplements in general, because just because the bottle says DHEA doesn't mean there's DHEA in it, unfortunately, because there's no one regulating some of those supplements. So that's something to be mindful of.
Yeah, I saw a report. I think it was in Andrew Goldstein's book. Was it Andrew? It was in somebody's book, and they did look at supplemental DHEA, and only 80% of them had DHEA in the supplements. And then of the ones that had the DHEA, it was of varying amounts, which wasn't accurate, which was what was on the bottle. So I think the problem with supplements is just buyer beware. You don't know what's in there.
Right.
Which is too bad, but it's an unregulated industry. So I get a lot of questions about vaginal estrogen and the proper amount, and is the applicator important, but isn't the goal the vulva? What is your kind of standard, if we're talking about creams for estrogen, that darn applicator, which so many women, they hate it, or it's messy, or it hurts them if they have tons of atrophy. So kind of what's your opinion on, I need to use the applicator, I need to use a large amount versus small amount? Give me your standard estrogen cream spiel.
So I think the spiel is no woman likes putting creams and gels in her vagina because it's goopy cloppy, and I have yet to meet. Actually, I've had a few women ask me for it, but almost always they hate it and they use it for a month. Or they use it for, until the bottle runs out, and they don't refill it because it takes 2 months to really even start to work. And it's only going to keep working if you keep using it. And so the key is finding a product that your patient understands why she's using it and uses forever, right? This is not like antibiotics where you use for a week and then you're done. Your vagina is never going to get estrogen in it again unless you give it to it, right? Your ovaries are never going to give you estrogen. And so treating these problems, and they get worse and worse over time. If you start menopause at 50, you're not going to notice symptoms until you're 60 or 70. And you're going to come in and say, well, I have urinary frequency, urinary urgency, sex is painful, and I'm really dry, but I'm not having sex because I stopped that 10 years ago because it was so painful. And then when you tell them that they need this vaginal estrogen, they say, well, I'm not having sex. And you have to explain, no, this is not about sex. And I think that's the biggest misconception is these drugs are approved by the FDA for painful sex. So you have to go to your doctor and say, I have pain with sex. We know from literature that women do not bring up sex unless they're asked about it, and doctors do not bring it up because they want to talk about just about anything else. So those words, when they don't get spoken, you don't give a person a prescription. And then you have a 10-minute visit to do all of the things. So it's going to get missed, which is why less than 6% of women are on treatment for their genitourinary of menopause symptoms. So my answer to the creams and gels and the estrogen creams are often what insurance covers. And so it's really figuring out with your insurance, what else do they cover? And Medicare just agreed, and I don't know if it's fully active yet, that they are going to cover they have to cover every medication in the class, I believe. And so you may start seeing a lot more coverage of things like Intrarosa and Imvexxy and Uvafem, Vagifem, and it's and E-string, and it's finding what works for your patient. So for the creams, if you, and we'll talk about creams. So if you use estrace or estradiol cream, it comes in a tube. It comes in an applicator that you fill up, and it's a reusable applicator, which women either love because it's environmentally friendly or hate because they hate cleaning it. You have to think of your vulva as external vulva and internal vagina, and both of them need estrogen. And so, yes, it's okay to dab some on the urethra for your urethral caruncle, but you're missing the whole vagina when you do that. And so I'll recommend a gram every day for 2 weeks and then twice a week. Would you be fine on a half a gram? Probably. Would you be fine if you did, a gram and a half or 2 grams? It's very vague the way the instructions have it. So that's why I kind of go in the middle. And I personally just say a gram every day for 2 weeks and then twice a week forever till death do you part. And please give them 11 refills or as many refills as humanly possible. It is even with me doing that. All the time I get women coming back and they say, oh, I just never refilled it, or I forgot to refill it, or I didn't know why it was important, even after I do the education. So everything with GSM is about education. It's about explaining why they have to stay on it. It's to prevent UTIs. It's to increase the acidity of the vagina so you can fight vaginal infections. And it's to keep you healthy. When you're 99 and you're going to get admitted for UTI sepsis, I want vaginal estrogen on board every day of the week. And so those little old ladies are real. And when they get sepsis, they die, as opposed to you want to protect them every way that you can. You don't want to start vaginal estrogen at 99. You want to start it at 50 to prevent the problems when you're 99.
What's your, I know my opinion, but what's your opinion of, congratulations, you've hit age, we'll make up an age, let's make up the age 50. Congratulations, you've reached the age of 50. Here is your script for your colonoscopy, and here's your vaginal estrogen cream.
So tell me your opinion.
That's my opinion. My opinion is if you care about your pelvic health, prevent UTIs, pain, you want to have a great sex life, women who have happy sex lives, they don't think about someday not having a happy sex life, right? But it's like I equate vaginal estrogen to sunscreen. And that's how I really get patients.
So I couldn't agree more. Again, but the urologists who see, X number of patients a day, we are not going to change the curve in terms of the less than 6% of women who are on it. It needs to be a campaign. It needs to be standard of care. It needs to be in every primary care guideline. It needs to be in every gynecology guideline. And it needs to not be an option. It needs to not be only prescribe this if they complain of pain with sex. As you know, I'm extremely vocal about getting urologists to prescribe this more because they actually see these patients in droves for urinary frequency, urinary urgency, recurrent urinary tract infections. And we have to get on board at doing it more. But as you know, many of our colleagues, both male and female, don't always do a pelvic exam and just to look and see how much menopause plays a role in these symptoms, because no one taught us that in residency. And so one thing I really want to focus on is teaching residents and teaching urologists how to do a proper pelvic exam, how to examine the vulva, how to look at when there's no labia minora, menopause, when it's red, raw, and irritated, menopause, when there's a caruncle, menopause, when there's no wrinkles or rugae in the vagina, it's menopause. And so you need to be able, every time you do a stone, every time you do a cystoscopy and you look down there and you see the difference between a 25-year-old vagina and vulva and a 99-year-old vagina and vulva, you have to make mental notes of there is a difference here, and how do we prevent worsening symptoms in our patients?
Yeah, I love it. I think a lack of education is everywhere, even in urologists or even in gynecologists, where the vulva is really something to get through to get to the vagina, instead of realizing that the vulva itself has its own normal and abnormal and pathology and kind of warning signs that you should look out for. What would you say are your two most, let's talk about the pelvis. Would you say are your top 2 or top 3 most common pelvic complaints or physical exam findings that you see in your clinic?
So I think urologists need to be better trained in how to examine a pelvic floor. So we focus on the urethra. That's about it. You don't need to do a speculum exam in everyone to do a good vulvar and pelvic floor exam. If you press on the labia majora like this and they say, ow, that's pelvic floor muscles, right? What's underneath the labia majora? It's just muscle. If you put your finger directly in a vagina and press all the way around it like a clock, including the urethra, and then keep going like this, and it feels like a tight muscle, or they say, ow, they have pelvic tightness and pelvic floor muscle issues, and they need to go to a pelvic floor physical therapist. And so doing those basic exams, you really can learn a lot about your patients. The other most important thing is find the problem. So if someone complains of urgency, see if on your physical exam you can elicit urinary urgency. If you palpate above the pubic bone and you elicit it, or you palpate at 12 o'clock in the vagina and they say, yes, that's my urgency, you have found it. Now you can do something about it. But I've had patients where all their urgency, and I showed this at Sufu in this great video, where all of her urgency was in her vestibule, which is her endodermal bladder remnant tissue right at the opening of the vagina. And that was her problem. Her problem was birth control and pelvic floor issues that was causing her urinary urgency. So if someone says they have pain with sex, it's not just pain down there. Is it superficial pain? Is it deep pain? Is it both? Where is it? And can you elicit their symptoms and their painful symptoms on your physical exam? Because if it's all in the pelvic floor exam, then you know kind of an algorithm where to send them to. So really pelvic complaints, it needs to not just be, oh, pain down there. You know, if I touch their vestibule and they say, ouch, that's my UTI, I didn't cause a UTI, right? It's not really a UTI. The reason they get postcoital UTIs is because when they have sex, it irritates their vestibule and they feel like they have a UTI. Macrobid only works because they take it and then it's a couple days after they've had sex, and so their inflammation and irritation calms down. And so I truly believe most of these postcoital UTIs are vestibulodynia.
Oh, totally. Do you see somebody who says, hey, I think it's semen? Tell me about the semen, or it's only when there's ejaculate in my vagina. Do you see any of that? How do you kind of suss out those specific complaints?
And again, you can work with them on, condoms versus no condoms and partners. And we see all sorts of, as I always say in sexual medicine, we don't get it right the first time, but we have to have fun trying, right? Mm-hmm. You have to be able to play detective and it's really fun, right? You get a problem and you say, okay, what do we know? What don't we know? And what can we try, to try to improve? Like look at a male with delayed ejaculation or delayed orgasm. And you're like, okay, is this a chemical problem? Is it a physical problem? Is it an anatomical problem? And then you move one variable at a time and you figure out what can we do to improve the quality of your life. And that's what makes my job so much fun. So I don't have a great answer for you other than I would take it case by case and say, okay, what if we acidify the vagina? What if we get a condom on? What if we, you play around with it?
Mm-hmm. Love it. 10 years from now, where do you hope to see this part of medicine?
It's a great question. I want to see it a part of medicine the way everything else is a part of medicine. I don't want to be seen as a weirdo for being interested in women's sexual health. I don't want the field of women's sexual health to have only one fellowship that you can do in the entire country. I want to see sexual health just being treated as health, because that's what it is, whether it's male sexual health or transgender sexual health or gay sexual health or straight sexual health. It's just health. And we have to do a better job at sex education. We have to have comprehensive sex education for doctors as well as for general people. And I think it needs to, I think the younger generations are demanding it more, which makes me a little bit hopeful, but we have a long way to go.
Tell us what you're doing as far as your activism on the educational committee for ISWISH. For people who don't know what ISWISH is, let's explain that to them too.
So I'm the current education chair of ISWISH, which is the International Society for the Study of Women's Sexual Health. Say that 4 times fast. ISWISH, it's a wonderful multidisciplinary organization that focuses on women's sexual health. So it is every discipline, basic science, MDs of every kind, sex therapists of every kind, physical therapists. It's a really great society, and all we care about is furthering knowledge of women's sexual health. So as education chair, we run courses every year, which we're going to have a new pain course that hopefully we will have if this pandemic ever ends. We have a yearly fall course where it's the nuts and bolts of sexual medicine, which is a really high yield one. Have you been to the fall course, Kelly?
Yeah,
It's a great course, right? Super great course. And we have an annual meeting every year where we do educational content in that as well. And so we're busy. We're doing a lot. We love when people want to get involved. We have patient advocacy now. So if you're a patient and want to get involved, we have ways for you to get involved now. So if you do have interest, definitely reach out to me and we'll help to get you more involved. I'm going to get you more involved, Dr. C.
Yeah, we're going to do a West Coast pain. My little pet project in the back is we're going to do that. You do your East Coast pain, and then we'll do a West Coast pain.
We're up for it. This is the first time we're doing it, so it's going to be, there's an interest. There's so much interest and there's so much need because this is such common problems, and we don't learn about it enough in our residencies and in our medical education.
Do you have any advice for the woman who, let's say she lives in the Midwest in a smaller town, and she's getting empowered because she's listening to these podcasts and she's getting the knowledge down and she thinks she knows what she's looking for? How does she find a doctor that can help her?
It's a great question. In the world of telemedicine now, it's changing rapidly. I mean, just in the last couple of weeks, I've had consults from Canada and Florida and sort of all over the place, Colorado. And so that's certainly one way is telemedicine. Another way is, again, go to the ISWISH website, go to the NAMS, North American Menopause Society website, and they all have find a provider tabs. So you can I think the quickest way to find doctors who are friendly to this is find a pelvic floor physical therapist and ask her who the doctors are that she works with, because they will know the woke doctors, if you will, the doctors who really get this, and then come with information and come with ideas and find a doctor who's willing to learn, right? Someone who says, well, I've never used Intrarosa before, but this sounds interesting. Let me find out more about it. And so the doctors who are open to saying, hey, yes, I've been in medicine for, 30 years, but there's always new things that I can learn. Those are the good doctors. Those are the ones you want to work with, not the ones who say, this isn't real. This is all in your head, because it's not in your head. I mean, it is, but it's other places too. And we have to work on all of you.
Absolutely. So Dr. Rubin, where can patients find you?
So our website is intimmedicine.com. Hopefully you can put it in the maybe the podcast notes or the notes. I am on Twitter at Rachel S. Rubin 1. I'm very loud on Twitter. I've been trying to up my Instagram game, although I have a lot to learn. It's at Dr. Rachel Rubin. And then I have a new Facebook page that I just launched, and I'm also trying to learn how to do that. And that's Dr. Rachel S. Rubin. So very confusing ways. Hopefully we'll put links to all of them. And I'm learning from Dr. C at how to do better at all of this, because I think it's so important what you're doing and how much you're helping women and men and couples and humans. And we're just grateful for you.
Oh, thank you. That's really sweet. Did I miss anything? Did I not hit on like a glaring, before we go, let's make sure we talk about?
Maybe we'll come back in other days and do a part 2, because I'm sure questions will come up. We didn't even talk about the clitoris, which is my favorite organ to talk about.
The clitoris. Like most people, we neglected the clitoris.
Totally neglected it, and I have crowned myself the DC's premier clitorologist.
Right.
And self-proclaimed. So I do think the clitoris always warrants a discussion, because as urologists, we see a lot of pathology that we miss, but that we treat in our male patients who have the same pathology. So there's a lot of fun stuff to talk about on that front. But I think we covered a lot in just a short amount of time. And I talk way too much.
It's perfect. And that's a great advice. What we'll do is we'll let all the comments come in and kind of get a second list of questions, and we'll do it again because it's been really
happy
fun.
to. Anytime. I love talking to you.
I love talking to you too. Thanks so much.
All right. Bye.